Okay, so Shelley here again with Integra. We're going to talk a little bit about supplies for when you're going to do an insertion. I have two different configurations here for the Licox. One is called an IP2P, one is called an IP1P. 1P, one probe, 2P, two probes. Two probes would be when they are going to insert the actual bolt. However you guys are measuring ICP, whether it be through your Camino or whether it be through a newer product that's currently in discussion, that would be two probes, meaning the PBTO2 catheter, aka the Licox probe, and your ICP. The one probe would be something where, let's say it's, a really bad trauma and you haven't necessarily, lost an exam, but you want to kind of know what's going on in the brain. And you've already got an EVD catheter perhaps, or maybe you don't, and they just decide they want to do brain tissue oxygenation. That would be the IP1P, one probe. So I'm going to open up these packages just so you kind of get an idea of what the configuration looks like and give you the most important piece of what you're going to be doing with these actual kits. So I'm going to open up the IP1P because I think that will be the one you most often use, because I think that they'll use EVD catheters. And what happens here is you've got two active pieces here. One is the probe, which we call a CC1P1. Notice the green card that's here. This is the green smart card that is the actual factory calibration to the particular probe. It is literally, it's stamped with the digit that it is. Like when I talked to you earlier about there being a probe number in the bottom right corner, that's this number. So what happens is Dr. Riordan, Dr. Close, Dr. Lee, they're putting one of these in. The first thing I want the nurse to do after they're set up and everybody's getting ready to, drill, or the surgeons are getting ready to drill, is say, I'll take the green card. And when you take the green card, notice there's an arrow here. There is an arrow on the side of the monitor, a red arrow. You will go arrow to arrow like such. It clicks in, you'll feel it seat. It has the little chip on it like your credit card. And then it's going to say no temperature probe detected, use the manual temperature input. But you're going to accept that because it just illuminated probe 567. And that's what's on that card. And of note, this is that particular probe. It says 567 serial number. And now we get to hear the alarm we talked about earlier. I'm going to hit that. And just to turn that off. That'll give me a 3-minute pause. It's going to alarm because it's picking up that there's a temperature that's abnormal, so just know that that's well within what's expected. So what's going to happen is that your surgeon is then going to open up the actual bolt. This is the IP1P, again, the single probe. I'm going to open it up because what I want you guys to know when you're assisting is that any bolt that's put into the brain for a probe is going to have a bit that's properly fitted to the actual bolt itself. So the rule of thumb is this: you use the bit that's in the kit or else the bolt won't fit. And I say this to you as nurses only because you're going to be assisting, and if you see them pull the cranial access kit drill bit out, then you know they're going to end up having to drill another hole. I'm fixing this here just for purposes of demonstration. You guys normally are not part of this aspect of it, but if all of a sudden you start seeing a wobbly bolt go into the head, you're going to know something was wrong, and it's going to be that they did not grab the right bit. So I'm going to put the bit on to the drill, just like so. Okay, so in my faux cranial head here, this is what we've got. I'm going to take the drill, put that aside. I've got the actual bolt here, and the bolt's going to seat now that I've got that. Now, what they will have wanted to do, and I don't have a blade with me, but this is key, is that unlike EVD catheters, we don't want the surgeons opening this with a spinal needle. A lot of times you'll see them when they're drilling for an EVD catheter, they'll go poke, 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 poke to open the dura. That is not adequate for a PBTO2 probe because it will damage the probe on entry. And the way that I'm able to see if all of this is going to work is that I have an actual Obturator. You guys are used to obturators from tracheostomies, any kind of stoma that comes through. Well, this is actually a burr hole. I place that obturator here, and the surgeon's able to put that down into the actual bolt and just swivel it. They're going to know if they get any resistance, and that's going to let them know if they've got an adequate durotomy, aka dural opening. I then take the introducer. I am going to seat that in the bolt like so, and I'm going to turn the wing nut maybe 180. I don't want to tighten this down yet because I've not inserted the probe. I've got a stylet in here that I'm ready to remove, like that. And there's a little bit of a resistance because it grabs that inner lining of the actual port. And then I'm ready to place. And note that I am sometimes saying catheter and probe interchangeably. I actually do that with this particular device a lot, but it is the same thing. So there is a covering here. When I take this off of the device probe, notice that this is moist. I don't know if you can see that or not. Hopefully it's illuminated enough on the camera, but you actually see the electrolyte fluid that it's seated and stored in. If this were to come out dry and you saw nothing at all, that it's not been an electrolyte bath within its encasement, then you need to stop, go grab another one out of the refrigerator because this is not good. And remember, what you would be doing is that this right here is serial number 567, so that means that smart card needs to come out of the machine and a new one needs to be put in. But this one's nice and moist. It's been bathed in the electrolyte solution. I'm going to insert this down here, and then this is simply going to fasten down like so. Once I've tightened down to the actual port, then I'm able to tighten the wing nut. The wing nut is never tightened until the end of everything is being inserted, and it's finger tight, and that's plenty tight there. You're then going to take the end of your cable for the Licox monitor, and you are going to connect as such. It has a little groove there, so you kind of know that it's going to go into there. There we are. Notice you come to the screen here, and this has very high numbers. For the next 20 minutes to 2 hours, it is going to settle in the brain tissues. That seems like a really long time. However, depending on the trauma, depending on the parenchyma that you're putting it in, it could take just 20 minutes. The rule of thumb is that once that number settles and stops, then it's good to treat. You're obviously going to be taking them to CAT scan. You're going to be, making sure that this is placed into the white matter. One thing I didn't mention is that when you put this probe in, it's pre-designated at a length of 3.5 centimeters, which puts it into the white matter tracts. Your intensivist, your surgeons will know this. This will come down, and like I said, it will settle in that 20-minute to 2-hour window. I do want to let you know that in about 25% of the cases that you will sometimes see it start at a very low number, and then it will drift up. Again, you're waiting for it to plateau. And in the meantime, 20 minutes to 2 hours really goes by pretty quickly because you've turned this on. Remember I told you in the last video that this is warming up for about 3 hours because it's calibrating temperature. You're not going to see a normal temperature in this particular video because I don't have it in the brain, and so it's giving me an external temp, not a brain temp. So by the time you've gone to CAT scan, you've finished all of your procedure, you've got the patient back, you're likely going to have already seen your number plateau, whether it has risen or fallen, and then you're going to be ready to treat per the algorithm or protocol that your surgeons have chosen. There's a couple different things that are happening right now. Boost 3 is a clinical trial that involves brain tissue oxygenation in the severe TBI patient. That may be something that they model here. CIBIC is also another algorithm. I'll provide Dawn with both of those, and it just kind of gives you some background on why we're doing what we're doing with PBT02. But in short, the snippet is that in Boost 2, there was a significant reduction in mortality and morbidity in the arm that treated both ICP and PBT02 versus ICP alone, to the tune of like 11% reduction. So pretty significant results, enough so that the federal government invested millions of dollars to put the Boost trial for the clinical trial 3 out to multi-sites across the US. Again, use the card, put it in. That's the biggest thing the nurse does. Make sure your smart card is seated. If you were getting a number like 0, let's say I plugged this in and we put this in to the tissue and I have a steady state of 0. 9 times out of 10, I'm basically going to ask you, did he take the 11 blade, or she in this case, and do a cruciate cut? Meaning you need to see them take the 11 blade and go X. Again, none of the, poke, 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 poke. That's not adequate. And then the other thing is that I always like to know that the smart card is seated, like so, arrow to arrow. Again, we had numerics there, so that's not as big of a concern. I'll check my cables, and then CT scan. If this is not moving, then the question becomes, if everything was done right procedurally, everything looked good with the actual probe when you inserted it, meaning it was moist, the card seated, everything looks fine there, then you could actually have it in what is already ischemic tissue. We think about this a little bit more in the stroke world, but if I don't have viable tissue, then that's not going to be moving. If I have a low number, and I'm going to say low for purposes of treatment is less than 20, brain ischemia and tissue death happens somewhere between 5 and 10, so that's why we're treating at 20. Normal is 25 to 35. So if we're treating at less than 20, and I put this in and my first reading is 15, if I don't trust it, and I'm going to tell you right now, you're going to have trauma surgeons, you're going to have some docs that don't trust it, then you're going to do an FiO2 challenge. You're going to put the person on an FiO2 of 100% for 10 minutes, and if you see that number go up, then you know you are in viable tissue, and you need to treat the number. And that's going to be done in 3 different ways. First is obviously oxygen. It's why you do an O2 challenge to see if this is an accurate number and is working properly. Second, you're going to be looking at perfusion, and also third would be like looking at carrying capacity. Carrying capacity as in like RBCs, how's the hemoglobin hematocrit if this is a polytrauma. Perfusion, meaning that you're probably going to be looking at things like perhaps, just like in your stroke patients, you may need a higher MAP to be perfusing the brain more. Things for you to bear in mind is that the brain tissue itself, just like it does not store glucose, it does not store oxygen. So if you have competing traumas, meaning competing types of orifices, organ systems that are also damaged, then there's a good reason why you could have really low PbTO2 levels in your brain, because it's just not reaching there, because everybody's fighting and consuming oxygen, meaning every organ system is doing that. So that's pretty much in brief what you're going to be looking at. Thank you.